push record. Okay, I start the recording. Okay, go ahead.
Okay, so we're going to start in the perioperative. We're going to follow the blueprint. So the first things that we need to know are the safety in the operating room. So you need the correct ID, the correct surgical procedure, the surgical site needs to be marked, and you also need to have consent. And then the safety patient care. This is where we need to wear and protect eyes and skin. So protect from exposure from laser beams, wear goggles and sleeve protection, be aware of plume inhalation and smoke. We also need to know the fire and electrical hazards, exposure to blood and body fluids, and then to wear gloves and rubber boots.
Okay, I remember one question came regarding the laser risk.
Okay.
And I don't really remember exactly the question, but I know there was regarding the laser. Okay. Then the eye, skin exposure to laser beam, the goggles, sleeves, protectors, and know the features and laser operation. Okay, that was a question.
Okay, so we need to know the laser risks.
Yeah.
Maria is really good at remembering test questions, so she's going to pop up and say if she remembers a test question about something, because she has like an amazing test question memory.
That's awesome. Thank you.
Okay. Then we also need to know the surgical risks and complications. And so the major risks include hypothermia, especially for the older patient, because they're more likely, because they have less fat, and they have less vasodilators because they're on medications. The other surgical risks, this is chart 17. They can also bleed out, have fluid volume deficit, hypovolemia, dehydration or electrolyte imbalances, nutritional deficits, the extremes of age, so old or young, the extremes of weight. They can get infection or sepsis, they have toxic conditions, immunological abnormalities, pulmonary diseases, renal or UT diseases, and then there'd be complications if they were pregnant, if they had cardiovascular disease, endocrine dysfunction, hepatic disease, or if they had a pre-existing mental or physical disability. And then the last thing to be aware of with anesthesia is if they have anesthesia awareness, where they're awake but can't report, and that happens in less than 0.2% of patients. For nausea and vomiting, we need to protect the airway. So always think airway for aspiration pneumonia, and treat with emetics as soon as they report any nausea or vomiting.
That was a test question too. Sorry, I'm losing my voice, but that was a question too. Whenever it said your patient reported like nausea in the post-op phase, what's the first thing you're going to do? And you're just going to turn them to their side because you don't want them to aspirate. Then you're going to treat their nausea.
Thank you.
So that was a question. And then there was another question on there about I guess risk during surgical procedures and like what you should do to prevent injury. So you always want to make sure that you pad the bony prominences on older patients because you can hurt their joints. So you want to make sure that those are protected. You can cause like nerve damage if you don't have the right padding.
Thank you.
Mm-hmm.
Okay. And then the hypoxia and respiratory complications, brain damage can occur within minutes. And with the hypothermia, she said to think that the room is cold and the IV medications and everything are cold. And so that occurs whenever the body temperature is less than 98 degrees. And then we have malignant hypothermia, which can occur 10 to 15 minutes after anesthesia has been given, but it can also occur in the PACU. And so the early signs and symptoms are going to be the general muscle rigidity, the tetanus-like movements in the jaw, tachycardia, oliguria. And then the late signs are going to be when they have, let me see. Okay, that the late signs is when the temperature can go up to 107. And you need to start thinking about correcting the dysrhythmias. So you're going to discontinue the anesthesia. You're going to give them oxygen, decrease the metabolism, and reverse the acidosis. And you'll follow the dantrolene or the Dantrium protocol is the medication for that.
Okay, I remember there are two questions in this. The earliest sign was tachycardia. Actually, the first one was tachycardia and the second was the muscle. Okay.
Okay.
But the first is the heart and then the muscle and then the dendrium was the medication. What medication you gave it for the malignant hyperthermia.
And then when they're in the PACU, they have to be on 100% oxygen.
Okay.
Okay.
Yeah. And it's a muscle relaxant.
Yeah.
The succinylcholine, that's what causes the malignant hypothermia, is when it's a muscle relaxant. So that's the medication that usually causes the malignant hyperthermia.
Okay. Then the PACU priority assessments. So when they get to the PACU, well, some of this was kind of combined. It's like a before and after. It's just all the priority assessments. So you're going to assess for any potential problems, the health history, the vital signs, allergies, and she specified banana, kiwi, avocado, and latex.
And was a question on that one, I think, that if it's allergic, I'm not really remember exactly, was the banana, that the person was allergic to banana, and then was a question about that.
Yeah. So banana, kiwi, avocado, latex, and then also assess any joint mobility issues. You need to have all the permits and do the patient education before. You need to find out how much alcohol they drink. 2 or more can lead to complications. They need to stop smoking 30 days before surgery. Then you need to know their respiratory status. And she said surgery might be canceled. For example, if they don't have COPD under control or something like that.
Okay, with the smoking, I think was a question, and I think we were confused about it, but it's 30 days before surgery. Okay, up to 8 weeks.
Okay.
I have a question too. So do you remember a question on that test about, the patient stated that they had something to eat, a couple hours before, and who you would notify first? So on the OB test that we took, it said to notify anesthesia. I remember when we took it with her with med-surg, it said notify the doctor first. And so I was like, I'm getting 2 different answers. I thought you would notify the doctor first and then let anesthesia know. So what's the correct order?
I would go with doctor, but I don't know. Just since she had it last.
That's why I was confused, because I was like, I put anesthesia in med-surg and it was wrong. So then I switched it to doctor and OB and it was wrong. I was like, what? It's 2 different answers.
There's no right answers in nursing school, Kim. It's just
I was like, you notify both, they're both important.
I think whoever it's on the answer, unless you have both of them, then you'll be in trouble.
That's true.
There was both.
Okay, then you are in trouble.
Okay. For the surgical asepsis, the goal is to keep out microorganisms. So all materials in contact with the surgical wound must stay sterile. Gowns are considered sterile from the chest to the sterile field. Gloves are considered sterile, sleeves are considered sterile 2 inches above the elbow to the stockinette cuff.
Okay, that was the question with 2 inches.
Yeah, so 2 inches above the elbow to the cuff. The sterile drapes, only the top of the drape is sterile. And then we know the outer 1 inch is not sterile, and the team needs to move from sterile to sterile, unsterile to unsterile. So the people who are sterile are the surgeon, the surge tech, and the first assistant. And the people who are not sterile are going to be the circulating nurse, the patient, and nursing students. And I remember she said nursing students. So,
okay, I remember the question about the laser. Laser, it will ignite the risk of fire in the surgery. That was the question.
okay,
Now, because I saw it, I remember.
thank you. And then it's, she said that it's not as common anymore to do the hyperoxia, which is the high levels of oxygen to prevent infection. But that was on a previous student's notes from their test. So I don't know, think about that and whatever you want. But Ms. Shelton said we no longer do that.
Okay.
During the review, Ms. Shelton also said to remember that the scrub nurse, because I think this was a question on the test where it said the scrub nurse is going to pour, I guess it says which person is not sterile. And it was like the scrub nurse who is pouring saline to the back table, because she's technically sterile, so she's not supposed to be pouring saline onto the table.
Yeah.
Yeah, I remember that one too.
But then she said that during the review, so I don't know. That might be kind of a question she's going to ask, is like sterile versus not sterile.
And the scrub nurse, they could either have a scrub tech or a scrub nurse, so don't get confused on the wording. It could be either. Okay, then the PACU priorities. We're always going to think airway. So you're going to wait till the motor and sensory functions return. The patient needs to be oriented, have stable vital signs, and no evidence of bleeding or other complications.
And they will be on one side when you bring them because of the risk of the aspiration. Unless they have the tube in, then you can put them supine. But if not, you have to put them on one side.
Okay. Perfect.
But you can't with the Aldrati score, you cannot release them onto the floor unless they have no nausea, vomiting, right?
Yeah, and
like their nausea, vomiting is under control, and their pain, is that right?
Stable blood pressure, adequate respiration, oxygen. That is what I have marked here.
She said we're not going to have a question about the Aldrati score.
Yeah, okay. That's true.
Okay, I think we can go to acid-base imbalances.
Okay.
That's okay. So I don't know what works best for you, but I use the Rome. I think that it works well. So I do Rome and then I go through and put in all the arrows. So we're always first going to look at the patient, assess, look, listen, feel. Then second, you're going to look at the pH, and this is going to tell us if the patient has acidosis or alkalosis.
Yeah.
Then you're going to look next to PaCO2, and this is going to tell us if it's a respiratory disorder.
Yes.
Then you're going to look at the bicarb, the HCO3, and that'll tell us if it's a metabolic disorder. And then she said what to report to the doctor. We're going to report vital signs, signs and symptoms, and the ABG result. And so know your normal ranges. And then we can just talk about like the highlights of each thing. So metabolic acidosis. The causes of metabolic acidosis are DKA, sepsis, which is also lactic acidosis. It's the same thing as sepsis. And severe diarrhea. It can also be from renal failure or shock. But the main signs and symptoms of metabolic acidosis, you're going to have the increased respirations in depth, which is the Kussmaul breathing. You're going to have headache and confusion because of the hyperkalemia, which then can also lead to dysrhythmias and shock. You can also have decreased blood pressure, nausea, vomiting, diarrhea, warm and flushed skin. but the patient can be asymptomatic until the bicarb is as low as 15.
Yeah.
And this one has an 80% chance of mortality if the pH gets below 7.
Yeah.
So it's really hard to reverse.
Was a question on our exam, and I didn't do it right. With some tube, the nasal gastric tube, and I didn't pay attention. I was focusing more on the CO2 and on pH, but actually the nasogastric, because you take a lot of the acid out, then you go in alkalosis.
Yeah, that's this next one.
Okay, yeah, but okay, go ahead. Now, can I give you some tips about this acidosis, the way I memorize the signs and symptoms? The pH and the bicarbonate, it's down, correct? Then you have the potassium and calcium up. 2 down, 2 up. Okay, they're opposite. Then if you have calcium up, automatically you have dysrhemia. No, calcium is the muscles. Hold on. Yeah, the muscle twitching. And the potassium is up, then you have the dysrhemia. That is what two of the things immediately I remember like that because of the arrow. Okay, go ahead.
Okay, so metabolic alkalosis, like Maria said, this was a question about suctioning. So the main causes are going to be severe vomiting, excess GI suctioning, diuretics, and if they're taking a lot of antacids. So she said, think of the elderly for this one.
Yeah.
They can also be from diuretics like furosemide and thiazides. You could use that to help treat this because you're going to help get rid of the potassium. So the signs and symptoms, just like Maria was saying, you're going to have on this one decreased calcium and decreased potassium. So you're going to think hypertonic muscles like Trousseau's sign. They're also going to have tingling in their fingers and toes because of the hypocalcemia. And they're going to have the dysrhythmias and tachycardia because of the hypoglycemia. Yeah. And then she said nausea, vomiting, diarrhea are all very common in metabolic disorders.
Yes.
Decreased GI motility, decreased respirations. So the respirations will not be as fast or as hard as they should be in this one. So for this, you're going to treat the underlying disorder. That's the answer for all of them. But you could also help get rid of the excess bicarb. And you could do that with normal saline solutions. Okay, then respiratory alkalosis. The causes of respiratory alkalosis are the hyperventilation, anxiety, fear of pulmonary embolism because they have that fear, panic attacks, mechanical ventilation, hypoxemia, and then this one she mentioned at the test review, the early phases of aspirin or salicylate intoxication. So that was one I circled. It can also be from gram-negative bacterial infections like E. coli.
Are you talking about the alkalosis?
Yeah, respiratory alkalosis.
And we have the aspirin in this one?
Yeah, this one was an early sign of aspirin toxicity.
Okay, I'm marking it. Okay.
The signs and symptoms of this are going to be increased but shallow rapid breathing, dizziness, loss of consciousness, lethargy. This one also has hypocalcemia. So both the alkalosises, the calcium is low.
Yeah.
And then because of the hypocalcemia, numbness, tingling, you can also have seizures. So for this, the treatment is to calm them down, breathe in a paper bag because we need to get off help the CO2.
And give oxygen. That is what she specified, even asked, and are you giving them oxygen? And I told no. And she told no, you give oxygen.
Yeah, okay. I remember that.
Paper bag and oxygen.
Oh. Sorry, I have to say goodnight to my littlest. Hang on.
Okay, go. Oh, can you tell me goodnight too?
Okay, sorry, he's the mama's boy. Okay, so then we have respiratory acidosis. And she said this is the easiest to treat clinically because oxygen helps unless they have COPD. So the causes of this are hypoventilation, and it's always due to a respiratory problem with inadequate excretion of the CO2. So you can have an opioid overdose, a neuromuscular disease like MS, or they can have COPD and their bodies have just adjusted, and usually their pH is low, so it'll normally be like 7.2 or 7.1.
Mm-hmm.
The signs and symptoms, you can have increased intracranial pressure, hypoxia, rapid shallow respirations, decreased blood pressure, pallor and cyanosis, headache, hyperkalemia. So the acidosis, they go up, and the alkalosis, they go down. So hyperkalemia, which will also lead to dysrhythmias, dizziness, drowsiness, loss of consciousness, and then hyperreflexia because the calcium's also up.
Mm-hmm.
So muscle weakness and hyperreflexia. Good night, love you. Sorry, everyone had to say good night now. My kids go to bed early. I'm a mean mom. Treatment is aimed to improve the ventilation. So we want better tissue perfusion. So we need to increase their respiratory rate or the amount of oxygen that they get, but we just have to have caution in COPD patients. But she said it's easy to do if they're on an event.
Yeah, and here she specified how often you give them Narcan. Every 3 minutes until it's resolved.
Yeah, she did say that.
That is specified.
Thank you. 3 minutes until resolved.
Yeah, that is what she specified because we were talking about overdose of opium.
Yeah.
Then you put them on oxygen, but then you have to reverse the opioid.
Thank you.
One thing that I wanted to share with you guys, and it's just how I remember it on the acid-base imbalances, because they're so hard for me, is that if a patient has an obstruction in their airway of any kind or depressed system, you know, like brain injury, bronchitis, emphysema, it's always going to be acidosis, right? And then if it's a condition of overstimulation, like a fever, hypoxia, hysteria, it's always going to be alkalosis.
Mm-hmm.
And I mean, that's just how I remember it, because, you know, they always give us the scenarios and it's like, oh, he has a fever and blah, blah, blah. And it's like, okay, so right away we can start thinking, okay, that's alkalosis more than likely, you know? So
that's
I
great.
don't know if that's useful, but I tend to remember it that way.
That is good. That's very useful. Okay. Are we good on acid base? And go to diabetes?
Yeah.
Okay. So I feel like we know diabetes pretty well, so we'll just go through it fast. Type 1, pediatric, so younger than 30, and it's the patho is the destruction of the pancreatic beta cells.
Okay, before you go further, was a question about, and I don't really remember exactly which word, but they were glycogenolysis. The glycogen is break down into glucose, and gluconeogenesis, glucose synthesized in the liver. I'm not sure which words was used in the exam, but one of them was used. Okay, then look over those 2 words.
Okay, so and that that is the definition of diabetes, what Maria just said. So the liver is where the conversion of glucose and glycogenesis comes, because it's stored in liver cells. And then the pancreas creates the beta cells that secrete the insulin. So those are where your 2 organs come from, pancreas and liver.
Mm-hmm. And beta cells are producing insulin. That was a question.
Yes, and the beta cells produce insulin in the pancreas, and the liver stores them in liver cells and converts glucose to and glycogenesis.
Yes. Good.
Okay, so the patho for type 1, we know that the risk factors for type 1 are early onset, familial, genetic predisposition, possible immunologic or environmental factors, and it's possibly triggered by a viral infection. It's sudden and acute, and the treatment is insulin.
Mhm.
Then type 2 diabetes, the beta cells still work, but they either don't have enough beta cells or the key can't open it to use the beta cells. So the first line of treatment is diet and exercise, and then we'll go to oral hypoglycemic agents. This is a slower progressive onset. The risk factors for type 2, you're 45 or older, obesity greater than 30 BMI, genetic factors, metabolic syndrome, hypertension, high cholesterol, belly fat, gestational diabetes, or a 9-pound baby, and if they're African American, Asian, or Hispanic.
Okay, there were 2 questions here. One, okay, in 10 minutes, my Zoom meeting will end up, but then I'll come in again. Okay, there are 2 questions. You treat diabetes 2, type 2 with a diet first before you give the medication. And that was a question. And then the risk factors, I think, was one of the questions regarding the hypertension, that the hypertension will cause diabetes. Okay, which means just look over the risk factors very well.
Yeah, I think that it's a potential for a good select all too.
Yeah, that's true
risk
too.
factors.
That's true too.
Okay. And then another red flag would be wounds that don't heal, women who have repeat yeast infections, and blurred vision.
Yes.
I specified with her because Ms. Shelton did not remember all of these exercise rules, but they have the exercise rules on here, and she was saying different exercise rules than what the book says. So I clarified at the second review because she told us things like you need to check your blood sugar before you exercise,
Yes.
make sure that you're not low or too high.
Yes.
If they're ketones, they shouldn't exercise it. And if they're low, they should eat a snack. But I asked her, do we need to know chart 51.4? Because that was from our notes. And then Ms. Jones said yes. So the exercise rules in chart 51.4 say that they need to exercise 3 times per week with no more than 2 consecutive days without exercise. They need to perform resistance training twice a week. They need to exercise at the same time of day for the same duration. They need to use proper footwear, avoid trauma to the lower extremities, inspect their feet after exercise, and avoid exercise during periods of poor metabolic control. And they need to stretch 10 to 15 minutes before exercise.
Okay, I think the footwear was a question coming from this chart. Yeah. And I think was the cutting the toenails, you cut them straight. Okay. And yes. You don't use any commercial solution for the calluses, for the diabetes. Or something like that was.
I remember that one.
Yeah, I remember that too.
Yeah.
So that one was chart 51.4 is where that came from. And then for the diet teaching, for type 2, you're going to teach My Plate or Healthy Choices and teach them exchanges. So eat this, not this. They need to be able, this was a test question I remember, they need to be able to maintain the pleasure of eating. Mm-hmm. And so we need to include cultural preferences, social and personal preferences when helping them choose food. Mm-hmm. And she likes this one. She mentions it a lot. They can have alcohol, but they have to have it in moderation. So they have to add that into their carb counting.
Yes, that's true, in moderation. That's true.
And it can cause hypoglycemia when they drink. So it's better to absorb the alcohol with other nutrients. You all probably know that. Maria and I don't drink. So I have to remind myself. And then for the fat, they need 20 to 30% of their diet to be fat. 50 to 60% carbs, 10 to 20% protein, and then they need 25 grams of fiber a day. And then their diet goals. Oh, okay, that was, yeah, from the exercise.
And I think, I'm not sure if it was on the quiz, but just 1 unit of insulin for 15 grams carbs.
Oh, yes, yeah.
Okay.
I'll get, I have that one coming
Okay,
too.
then. Okay.
Okay, the criteria for diagnosis of diabetes. This was the word Maria asked about because
Yes.
she put it on the blueprint as POC, point of care, a random point of care. And we clarified that that is just a casual plasma glucose stick. So it's just a finger stick. That's what POC means.
Yeah.
So the criteria diagnosis for diabetes, they have to, number 1, they can have symptoms of diabetes with a casual glucose stick greater than 200, or they can have a fasting glucose of greater than 126.
Mm-hmm.
They can have a 2-hour post-glucose load during a tolerance test that's greater than 200,
Mm-hmm.
or they can have an A1C greater than 6.5.
Yes.
And if they're diabetic, it needs to be less than 7.
Yeah, and one question came out from this diagnosis findings, and I don't remember exactly which one, but one of them.
Yeah, I agree. It was, though, I think there will be one of those on
The-
how the criteria.
The hemoglobin A1C has a different name, hydrolyze or something like that. Just look to the full name, because was a question and didn't use it hemoglobin, use another word for the hemoglobin. Okay. But was referring to A1C.
Okay.
Okay.
And on that fasting blood glucose that's supposed to be greater or equal to 126, it's at 2 separate times, correct?
Yes.
Okay.
Yeah.
Just making sure.
And don't take food for 8 hours.
For the fasting.
Yeah, for the fasting.
Yeah.
Okay. And now the signs and symptoms for the hypo and hyper.
Yes, I drew Angela's chart on my notes because Angela's the best. So if you have Angela's notes from this, I did it just like that. So
I don't have them. Will you send that to me in a text whenever
yeah, I'll
we're
take
done?
a picture of it because
Yeah,
I
okay,
go back
awesome.
to Angela's stuff all the time. She's
Okay.
the best.
Thank
But
you.
we'll go over it super quick. The hypoglycemia is less than 70. If it's less than 40, it's severe.
Yes.
The causes of hypoglycemia are too much insulin or not eating or too much activity. Signs and symptoms are increased heart rate, sweaty, shaky, anxious, hungry, blurry vision, weak, tired, headache, dizzy, nervous, upset, clammy, or cool. And this is the treatment Maria was talking about. So first, we're going to give 15 grams of fast-acting carbs. And that's the example of 4 to 6 ounces of juice or soda. Then retest the glucose in 15 minutes. And then retreat if they're still less than 70, or if symptoms persist for more than 10 to 15 minutes, or if testing is not possible. So if you're just like out in the community and you can't test the sugar. And then you need to follow up with a protein and a carb snack within 30 minutes, or if they're going to their next meal, that's okay.
Which means that you have to treat twice with the juice before you give the protein. That was a question.
So.
And don't forget about tachycardia in the hypoglycemia.
Yeah, I just called it high heart rate, but you're right, it's the same, tachycardia.
Yeah, I remember there was a question about tachycardia.
Okay, and then it's an emergency if the patient's unconscious or they can't swallow. So if you're in the community, you'll give IM glucagon 1 milligram. And if you are at the hospital, then you'll give 25 to 50 milliliters of 50% dextrose IV. And then hyperglycemia is greater than 120, and the causes are not enough insulin or dehydration. And the signs and symptoms are going to be headache, muscle twitching, hyperkalemia, nausea, vomiting, diarrhea, warm, flushed skin, increased respiratory rate, because this is the Kussmaul breathing, decreased blood pressure. And the treatment is for DKA, it's the same for HH&S, but you're going to do the fluids and then insulin and then monitor the glucose. So it's always fluid first.
Okay, I need to turn it off. Okay, and I will enter again.
Okay. Did you record it? Uh-oh, did we?
Yes, I did.
Okay, okay, perfect.